So I want to talk about cancer-related emergencies, which is not a terribly exciting topic. Last topic was much more fun, which, if anybody remembers, was what mysteries that we try to solve, some of the famous deaths. So I try to make it a little bit more entertaining by pulling up some cartoons, which nobody's paying attention to. So I'm kind of disappointed. It took me hours of Google imaging to find something kind of funny, but not terribly morbid. All right, finally, somebody got it, or he's laughing about something unrelated. So cancer-related emergencies. So one thing, I have a lot of respect for oncologists because I think, unlike all the other specialties, they really have to know a lot of medicine. I feel like nephrologists, they get very focused on their kidneys. But oncologists, they have to go across all specialties. They have to make sure that they have colleagues in surgery that work with them, colleagues in radiation oncology. And there is also cancer-related emergencies, which we have to know about. We used to have a huge cancer service at Weiler, which I know dwindled down, but I know Moses still does a lot of cancers. So I've actually broken it up into 3 different things, and hopefully if things go well, I'll come back to do more topics later. So cancer can cause problems by different mechanisms. One is just whatever locally tumor can do, which what tumor does to adjacent tissues, which is compression symptoms. The other one is metabolic derangements, which is the most interesting, the most fun out of all of them, which is your hormone imbalances, electrolyte imbalances, which can be due to cancer or due to chemotherapy. And the third one is myelosuppression, which is your infections from neutropenic fever. I think somebody did neutropenic fever this morning. And blood component deficiencies, which can also become a big issue in the ED. So local tumor compression, there's 4 major syndromes, 2 of which you're pretty familiar with. So airway obstruction, you should be not a stranger to that topic, and pericardial diseases, not a stranger. But 2 others which do show up, and we don't see them very frequently, there's cord compression and Cauda-Equina syndrome and vertebral Mets. We see it, but we don't see it very much. And then the last one is superior vena cava syndrome, which is not unique to cancer, but you have to know about it. It's a nice question to show up on your in-service exam. Some of you know I recently recertified, so what I actually also did in this topic is I italicized some of the things that I thought I have seen during questions during my board prep and board study. So I look at it as freebie answers in a few months. So we're going to start with epidural spinal cord compression and vertebral Mets. I don't know if you guys can see the cartoon. So really, Mets from any tumor. So ESCC stands for cord compression, epidural spinal cord compression. So Mets from any tumor can cause it. And vertebral Mets are actually more common than cord compression. And what's interesting is 85 to 90% of cord compression is due to vertebral Mets. So they seem to run together quite a bit, but they're how we manage and how big of an emergency it is a little bit different. Cancer-causing tumors. BLT in a kosher pickle. Somebody remembers that one? So breast, lung, thyroid. Oh, and I threw in the Mayo, multiple myeloma. Multiple myeloma loves your bones. Kidney and prostate. So BLT, multiple myeloma, and then kosher pickle is kidney and your prostate. A lot of prostate patients will have bony Mets. It's a big issue with them in terms of pain. Location within the spine. Thoracic. So this one came up. Beautiful board question. What's the most common site where you're going to have vertebral Mets? Thoracic. The big question is why?
It's where the canal's narrowest?
Nope. It's actually very simple. I can't hear you. Nope. No, it's simple. Think about how many vertebrae you have. It's 12, right? So it's just like statistically more probable to have. And the same thing, there's predilection for osteo and for TB. POTS. Not that we see much POTS disease from TB, but loves thoracic. So that was a beautiful question. Examiners love this one. So pathophysiology. So tumor can cause injury through bleeding, because if the tumor, the vessels become friable, there's extra blood supply, so that you can have epidural bleeding, and that can cause issues for the patient. You can have infection. You can cause fracture if if it destroys the bone. Or you can have direct compression. And the mechanism was interesting. So tumor grows and then starts to encircle the thecal sac. And then it literally just strangles the tissue because there's no circulation. And so as the venous plexus gets obstructed, it's almost a mechanism for DVT. You can't have the blood flow, and then the spinal cord starts to swell, and that's when you have the symptoms, which is why we're going to go a little bit later. One of the first lines of treatment is going to be steroids, because we're trying to get the swelling down. So what are the clinical manifestations? Again, highlighted in red. So I had a lot on the questions. What is the first manifestation? What is the most common manifestation of spinal cord compression? Nobody knows how to read. Pain, right. So 83 to 95% of patients will present with pain. What was more disturbing to me is that it's 7 weeks. So it can present as early as 7 weeks before you see anything else. So obviously any cancer patient with back pain, be wary. The other thing, again, highlighted, I italicized it, severe local back pain. If you have someone who has progressively increasing pain, right? Because if you think about the natural course of, I lifted my 4-year-old and I strained my back. What should happen in the next month to my back? Dan, I should feel better, right? Truthfully, the research shows, no matter what you do to me and how fancy the things you do to me is, it's going to get better. What about, so pain worse at night, right? Because if you think about it, most people, they say, I'll feel better lying down, and then I feel worse when I'm doing activity, if it's a muscle strain. That's why if you ever pay attention, like you get more back pains reporting to you in the morning because they just can't get out of bed. It hurts, because I've been in the same position for a long time and my muscles are stiff. Or if pain that's worse with a supine position, because we're talking about direct pressure. Again, very contrary to what we would normally expect from our muscle strain. Pain can go down a limb with movement or Valsalva. So Valsalva in particular, because we're increasing the pressure in the cord. And oftentimes pain is bilateral. So the second most common symptom is weakness. Again, the location of how much weakness you're going to have is going to depend on where the tumor lands. Obviously, the higher it is, the more in trouble you're going to be. And then it can eventually progress to the point where you can't walk and you have paralysis. So something else, so again, and highlighted, so symmetric weakness. So things that should raise concern for me that this is going to be a cord compression or something more serious than the usual muscle strain. If I have bilateral symmetric weakness, now I can't think in medicine of a good reason that I should have bilateral symmetric weakness. I just can't. I feel like that's just a no-no. Right? Bilateral symmetric weakness, that's like Guillain-Barré, ALS. Like that's just not a good symptom to have. They get hyperreflexia if it pushes on a cord, right? Because that's our upper motor neurons, and they will have a positive Babinski. Cauda equina is the lower motor neuron, right? If you think about it, because the cord is up above, and so you will have hyporeflexia. So when was the last time you checked reflexes on your patient with back pain? Right, me too. So you can.
I think you do it. That's diagnosis specific, right? Like we're not doing it routinely on everybody. But
no, we're absolutely not. We're not. But it is a beautiful thing that I can torture you on your in-service exam, right? Because on a board exam, I can ask you all kinds of esoteric things that you probably don't do in real life. So if you have a laterally situated tumor, you can have isolated motor radiculopathy. So then you're a bit at a loss. There's no red flag there. So how much trouble you're in depends on where the tumor lands. T6 is our paraplegia. That's T4 is the nipple line, so T6 is a little bit lower. If you have C6, then you lose your tetraplegic, meaning you can't control arms or legs. And L1, you're going to be paraplegic, legs only. So the next symptoms, which is less common, is sensory. it's interesting, they were saying ascending numbness and paresthesias. I didn't know it was ascending until I started preparing this. Whenever I see ascending, I think Guillain-Barré, right? That's the classic ascending. I had a cold last week, and now I have ascending paresthesias and weakness. So if you have cauda equina, you may have saddle anesthesia, and that's a classic question we ask to patients, right? Can you feel yourself wipe? Can you feel your butt? Can you feel your vaginal area, your penile area? You can also have sensory can be symmetrical if it's in the cord compression. Bowel and bladder dysfunction. So you can have it, or you can have, or it doesn't have to be there. Like classically, whenever I think about cord compression, I'm like saddle anesthesia, bowel bladder symptoms. Like you have to have those too. But it turns out you can get condus medullaris and back pain, and all you have is inability to control your urine and bladder, and you're fine otherwise. You can walk. So go figure. That's a good little red herring there to throw me off on my clinical diagnosis. In terms of bowel and bladder dysfunction, this is a big source of confusion, and I know, like, it, you know, again, recently I researched it and I realized, so we ask patients, are you having urinary bowel incontinence? It's not. It's urinary retention, and you can have overflow incontinence, meaning my bladder is like so full I can't keep it in anymore, and it's bowel incontinence. And ataxia. Again, ataxia and back pain in a cancer patient is bad news. So how do we come up with a diagnosis? I think most people will probably know the answer to that. One thing to get, so what's the test of choice? Like, what do you got to do? The one time in an ER you have to do it.
The DRE.
The DRE. Yes, you do, because that should be, you know, you want to assess for saddle anesthesia, you want to assess for rectal tone. But in terms of diagnostic studies, MRI, you have to do that much hated MRI, which involves 6 hours and begging and pleading and hourly conversations with a radiologist. It is the preferred imaging modality, and you have to do the entire spine. So occasionally we have folks and they are like, well, no, it's the L-spine back pain. That's where we're going to focus on. But if you're worried about cancer related, you have to do the entire spine, because oftentimes it's more than one spot that got seeded. And so MRI is a preferred imaging modality because you can see the bone, you can see the cord, and you can actually make a judgment about how much the cord is being pressed on. Another option, which I've never used, so did you ever do this one, CT myelogram?
You don't even need a myelogram sometimes, you can just do the CT.
So I'll get back to that. So the proper test to do is CT myelogram. It's actually incredibly risky. Like, we don't do it. My understanding is you would have interventional radiology do this. It's very invasive. And then I was like reading, like, the side effect is, like, if there's a lot of pressure below the cord and they put the needle in and they drop the pressure, like, you can actually make the situation worse, which I'm like, oh, that sounds like a great test. Sign me up. I'd love to send my patient for a test where they're going to become permanently paralyzed. It's a no test, but the only reason I left it in is because for some patients you can't do the MRI. So mechanical valves, your pacemakers, defibrillators, foreign bodies, or implants. So I wish you good luck. I've never actually tried to order this test. I don't know if it's still done by IR, but it's something to think about for patients that have contraindications to MRI. And that's a picture of an MRI. Is there like a laser? Nope. Oh, there we go. So normal vertebra, nice and square. Well, that's not normal, right? So something that doesn't belong there.
I don't know. It looks good to me.
It looks good, right? The dark line is supposed to be in the normal spinal cord, and this little thing is wreaking havoc. It's even I could read that one. So other diagnostic options, CT non-contrast. The problem with non-contrast CT, it doesn't reliably demonstrate spinal cord or epidural space. So you call, you get these readings occasionally, and they talk about cord compression. Then you try to call ortho, who is our people on our campus who are supposed to deal with spinal cord issues, and they're like, you can't make a judgment based on a CAT scan. And they have a point to that. But again, like the next option is CT myelogram, like good luck. And so the other one, I thought, bone scan might give us a test, but truth is it doesn't, it just highlights. So it'll tell me if there is a MET there, but you can have false negative MET. And it doesn't give me information about what's happening to the thecal sac, because it's literally like a picture of a skeleton with things highlighted on it. And plain x-rays, super easy to obtain. It's usually our first line choice, but sensitivity of it is meh. And all you're really looking for is there a bone destruction? Because if you have bone destruction, it raises your suspicion that there's going to be a problem in that area. So treatment. Why is it important? So this is one of the can't miss diagnoses. Why is it important for me to treat the patient right away?
Because you don't catch it, it's permanent. Right? This could become permanent.
This could become permanent, right? So it's like with subarachnoid, the way I explain to patients is the earlier I catch it, the better your neurologic function is at time of diagnosis and time of treatment, the better your prognosis is going to be. And there's the most important prognostic factor is how much the patient can function. Can they walk at the time when I made the diagnosis? So we need to rapidly intervene, and goal is one, pain control, because these things are incredibly painful. If any of you ever met prostate cancer patient with bony mets, they are miserable. This is the patients that you're escalating narcotics on, and they need real pain management, not the, it's full moon and I ran out of my pills pain management. And then you try to preserve the neurological function as much as possible. So there's a lot of options here, and I included them. Most of them are not going to be done in the ER, but I think it's important so we know, so at least we can be aware of what's out there. So obviously the first one's pain control. Okay, I can handle that, right? Like, because you got to make them comfortable. They have to lie still for that MRI for 45 minutes. And if you imagine you got a growth on your back that hurts and you can't lie still for 45 minutes, it's not going to be a good quality study. Steroids, big part of it. And interestingly, they're saying pain improves within several hours. So it's given pretty liberally. Unless you have a small lesion and you have pretty much no normal neuro effect, and there's really, you're fine. Surgery, it's really reserved for patients with unstable spine, but you also have to have a decent pre-function and decent prognosis, because that's spine surgery is a big deal. There's no point putting somebody who is in stage 4 cancer and has less than 6 months to live, putting them through surgery. That's just going to kill them off faster.
Do you have any comments about a good story, knowing the delays in MRI right up front, lasting with steroids?
Do I have a good story? No, but
comment on just
blasting them with steroids. I think if I have, usually when they get referred, I'll have a private oncologist, and so I get them involved early. People that work with me know I have my magical phone book, so I get people pretty early, and they usually come from an oncologist's office with this is what we think is going on, but it has to be high-dose steroids.
So you're hesitant in doing it empirically. If you're alone at 2 o'clock in the morning and you can't get the oncologist, you would or would not give steroids. And I'm not putting you on the spot because I don't know that there's a...
I think I'd have to use...
I personally do.
Right. I think I'd have to use on what your degree of suspicion is, because you're right. I mean, that MRI, I tell people, it's like a 12-hour process.
Right.
It takes me 6 hours to get you in the machine on a good day, and it takes another 6 for me to chase down the reading.
So what is the downside?
Well, the downside, you're talking about infections, you're talking about poor healing, so there is downsides.
If you're talking about the spine, I don't really think that there's a downside.
Yeah.
Right.
I think it's teachable. I think get it blast hard.
Yeah. And it's high doses. You're like, it's not the prednisone 40.
The problem is what dose, right? The dosing that you hear is all over the place, right?
Yeah, that's why I don't think there's I think no matter what you do,
Yeah.
if you look at it as a ones and zeros, you did it.
Right.
So for me, I give Decadron 10.
No, it should
Because sometimes you'll hear 50 or 100.
What?
No, it's crazy doses.
7.5.
I'm sorry?
There's some inside joke there to which I'm not privy, but
But at least you could say we gave the steroids,
Yeah.
we
Right.
initiated it, right? And there's no evidence to say what. I mean, I don't think there's any good evidence comparing different dosing, right? Even though you'll hear them give.
I think
These
as long
monsters.
as you're supra-adrenal, you're golden. And apropos to my talk last week, I've reviewed at least a dozen of these cases where the ER doc was brilliant, made the diagnosis, and went down because they didn't give steroids.
So was that in a setting of trauma, or you were talking about specifically in a setting of oncology?
I'm telling you exactly this.
this case, yeah. I feel like in this case, you're right. There isn't much downside if you're suspecting bony mets, because I mean, it seems like there's actually reasonable explanation for why they work well with oncology patients. But from my understanding, it's very wishy-washy when it comes to trauma and spinal cords.
Yeah, no, I have no experience.
Because that's, so I don't know if you still do
I
that.
think that was debunked, right? Like, because there was a, right? We were
You don't do that anymore, yeah.
steroid protocol, and then it was debunked, right? Like,
That's my understanding.
Yeah.
of the
Yeah,
literature.
I think that was,
yeah.
but when I was in,
But
like,
you
there was
will
still debate.
hear some neurosurgeons pressure you to do it anyway. But
Right.
That goes back and forth, doesn't it? Isn't that
Yeah.
cycle back around every 2-3 years?
But there, remember there was that whole protocol that was existed maybe 15 years ago, right?
Yep, 100%.
And people got in trouble for not initiating that protocol.
Right, there was lawsuits, and it would like, and then, yeah.
So you're talking about an acute event, an acute change, or someone who comes in, with lingering weakness for a few days, and you suspect spinal cord compression, as opposed to someone who came in suddenly that morning.
I think as soon as you entertain the diagnosis of spinal cord compression, to the point that you're getting an MRI, that's when you initiate steroids.
Because the evidence is they're basically saying, unless you have minimal symptoms, you have a normal neuro exam, there is benefit to giving steroids. And they talked about different levels, like you can pull the up-to-date article. They'll talk about different levels, like based on how bad your symptoms are, what the dose to go for. So something I know, they don't do it in the hospital, but I know it does exist in Weiler, is something called vertebroplasty and kyphoplasty. And that's also done by IR. It's a pretty cool procedure where they'll go into a vertebra that's messed up from osteoporosis or from cancer, inflate a balloon, and then fill the hole with, my understanding is dental cement. And then you have pretty good. So that's also an option for patients with osteoporotic compression fractures with a lot of pain. And again, it's good for patients who are not candidates for surgery, and also they can't have epidural disease, and there can't be retroprolapse of bony fragments, because it's minimally invasive. Like it's like drill. So you don't, you can't go through the. If you're going to go through the met, it's not going to work very well. And so the last one, which is why it's always worthwhile to get oncology involved, is they can do radiation. And it can be external beam, or it can be stereotactic body RT. And there's whole oncology protocols, which I didn't include because I just figured, we're not going to be making those decisions, but we have to know what's out there so we can get their oncology involved early, and they can do this. I also know they don't do it in the hospital. So it's something that the patients have to leave, and they go, there's like a Red Onc Center a couple of blocks away from Weiler. I thought you might be entertained by this one. I've done this surgery several times in workshops, never saw this much bleeding. Well, they were cadaveric workshops. All right, so cancer-related airway obstruction. Beware of inexperienced, ambitious clinician who wants to help. And we see a very unhappy patient there. So cancer-related airway obstruction. So that can be 20 to 30% of lung cancer patients. It's primarily focused on lung, but truth be told, anything that lives in your thoracic cavity can cause trouble. And it can be broken up. There's central, which is your trachea and mainstem bronchi. You can have upper airway, nasopharynx, laryngeal, proximal tracheal cancers, and lower airway, which is the small bronchi. So it can be extrinsic or intrinsic compression of the airway. So you can have something that's growing inside the airway, or you can have something that's pushing on the outside. And what kind of cancers can cause this kind of trouble? Dr. Kane, I know you can read.
All the midline ones.
I think it's primary lung cancer.
Right. So the most common cause is lung cancer. Again, another freebie for the exam. And anything that lives, so tumors that likes to go to the lung, and anything that lives in the chest cavity. So your esophagus, your thyroid, all those things can cause trouble. And so this is etiology with a picture. So you can have endoluminal, so tumor that's growing inside the bronchi or trachea. You can have extrinsic compression, so that's anything that's pushing on from the outside, and mixed. And of course, we always bronch patients in the ER, so I threw a picture in. So you can have different ways in which it can cause trouble. If it's endobronchial, it can cause infection by blocking the airway. And of course, you can have airway wall edema because there's inflammation, infection, or bleeding. So usually the presentation is subacute. This isn't the I was fine yesterday and all of a sudden I'm not. So it's something that's been going on for some time, and then something happens and all of a sudden they deteriorate. So symptoms are very nonspecific. It can have shortness of breath and your hemoptysis and cough and stridor, upper airway. If you see stridor, that's, especially on exam, they're trying to tell you it's upper airway problem. Wheezing that's unilateral. So unilateral wheezing in a kid on the exam is foreign body. I don't know how to get the peanut gallery involved. In an adult, you have to worry about cancer. So weight loss, in the laryngeal cancer, you'll have hoarseness and voice changes. Esophageal cancer will complain about dysphagia. So something else on the bottom, which is interesting. I'm coming for the peanut gallery. I'm coming after you. So if you have somebody who's been on antibiotics, can you hear me okay in the front? So if you've been on antibiotics for 4 to 6 weeks and they don't go away, you have to think about possibility of something obstructing the airway and causing, I'm blanking out. No, the pneumonia. There's a specific term for it. So help me out. Post-obstructive pneumonia, thank you. Brain's not working. So the first priority, as always, is stabilize the airway. Airway, which can be quite challenging. You obtain your diagnosis, you can do a chest x-ray. It's helpful. It'll give you a clue. CT chest is obviously better, but you can't do it until your patient is stable. And if they're having any airway signs, putting them flat on their back may not be the best idea. And of course, bronchoscopy is the gold standard. So I threw in some chest x-rays. There is something in there that doesn't belong. There's another picture of that. And that's the CAT scan for those that are good at reading CAT scans. This is our vessels, and that's, hello, I don't belong there. I'm sorry? No. I think it's supposed to be a tumor.
No, I mean next to it.
It's ending.
I think they have a lot of problems.
The tumor may not be killing them quickly. So in terms of difficult airways, so a couple of tricks, right? This is the guy or the lady that you can get in trouble with quickly. You have to anticipate that this is not going to be easy. And you have to have your plan A, plan B, plan C. This is the one that you could potentially want to have your ENT on board because you may need to crike or trach them if there's a big problem with the lesion. They do recommend using a larger T-tube so that our pulmonary friends can then go in and bronch the patient and get the diagnosis. If the lesion is above the cords, you may not be able to pass it, so you have to be at least mentally prepared that you have to crike. And they talk about using LMA as a temporizing measure, but truthfully, if you have a hard airway obstruction above it, I don't think LMA is going to save you. One option is retrograde intubation, rigid bronch. Is that even around? Do we have that in the ER? The rigid bronch, no. So retrograde intubation is something to think about, but I think realistically this is going to go down quickly to a crike.
Have you ever seen somebody actually consider retrograde?
They're not that hard to do.
They're not hard. They're not hard to do, but I think in this setting, my thing is like, it's not going to be easy.
Right.
Because there's obviously
you already have
ball of
something obstructing your airways.
Right.
So, I mean, your risk of coiling the wires.
Exactly.
Is high.
Exactly. There is a TV show that was out. It was a sitcom called Royal Pains, where they talk about all the crazy medical procedures, which none of them are realistic. And of course, the protagonist, all his patients are blue, and he takes 20 minutes. He makes his own. They fall into some pit with gases, and the guy manages. He had tools in his bag. He cut up pipes, and he made a T-tube, and he did retrograde intubation. And I'm like, while your patient is cyanotic, and they all wake up. Sign me up.
Neurologically intact.
Neurologically intact. I love it. Yes. And then he manages, of course, to get them all out. I was kind of intrigued by the idea of like how he used to vent them while he's dragging them out of this pit. But I thought the idea of the procedure was entertaining.
I mean, retrograde, Yeah, I used to, in an airway course I ran, we occasionally would teach retrograde intubation for something that was almost never done ever, or even
Right.
considered. And so if you actually have the kit, which most places don't even have the kit, it actually takes quite a bit of training. And even if you have to do it like a multiple times in a row, it's a long procedure. So it's not something you would do.
It's not that. I mean, it's not that long. I think you're talking about maybe an additional 10 to 15 seconds compared to your surgical cric.
I mean, I think your surgical
That's
cric
if everything
with a
if everything's available.
So,
You have to get the
surgical
wire.
cric with a bougie is a very quick procedure.
Right.
Once again, I've taught this retrograde procedure, like and with the kit and with everything, and with practicing it is not an easy procedure. It is not an easy procedure to do, and there are some issues of getting caught up. This will get you in trouble if you're trying to make something on the fly. You know? I think you're much better off going for cric.
yeah.
I don't know. Anybody else have any experience? Or
You don't need a kit.
you can do a central.
You can use a centralized kit, but I think my concern would be if there is a mass that I know is going to be friable, and I accidentally poke it with my, am I going to then, maybe I should have just gone for a cric, because now he's going to bleed all over the place, and I have bigger problems than I started with. So other treatments, first you secure the airway, make sure everything's okay, and then bronch. They're saying within 12 to 24 hours. I don't know if I can convince my pulmonary guys to do it that quickly, but I can usually get pulmonary to see him the next morning. And bronch is nice because it can be diagnostic and therapeutic. So they can treat the lesion, they can burn it with a laser, they can stent it. And other options, which are obviously not ER options, but you would involve the patient's oncology, would be radiation, chemo, potentially surgery. So hemoptysis. So going back to why I don't necessarily want to muck around with a friable mass in the airway. So all these people, like in the old days, La Boheme, which was the opera, there was a spin-off in the 90s, which was called Rent. So La Boheme, right? The girl dies from TB. They made a Moulin Rouge. There's a movie, Moulin TB, yeah. I'm sorry, I was referring to La Boheme. So there's a movie that they made later with Nicole Kidman.
Great movie.
Moulin Rouge, right.
Eyes wide shut.
Moulin Rouge, we're talking about classics here. La Boheme. Oh, with Nicole Kidman. We're referring where the girl dies of TB, and so the question is, does she die from exsanguination or asphyxiation? Who can read? So hemoptysis is bad because you drown, right? It doesn't take much. It takes a cupful of your own blood to fill the airway and make your gas exchange impossible. Which is why hemoptysis, at least in my book in the ER, I don't care how little it is a big deal.
Just related to this and before, does ECMO have a role in any of these patients?
I don't know. I don't have ECMO on my campus, so I couldn't even tell you.
Yes, you do.
You do.
We have ECMO?
They're all up in the CTICU.
I'm saying, meaning how bad does an airway have to be? I can imagine that a mass could make an airway
So-
bad enough that you might need to bypass it completely.
So let me ask you in a trauma setting, have you used ECMO? In trauma, like if you have blood aspiration, that would probably be the good place to.
At Jacoby, we would need to get them. Actually, we have to get the mop of your team to come over and do it. And so that becomes. We actually had a case last week with a massive pulmonary embolism where you actually had to have the ECMO team. So it's not a. Right now, it's a very.
But we're talking about in a setting of hemoptysis. I imagine the answer is yes, but the practical aspect of it might be a bit complicated.
I just don't see how big. I mean, when they go down, they go down.
Right.
I don't see how. Like the by the time you pick up the phone.
It's a theory. I hear ECMO is a new way to go anyway with the whole ACLS thing. So it doesn't take much. So goal is you want to, in the ideal situation, you want to tube the good lung, right? Because this way we'll close off the main stem bronchus, and hopefully the blood stays in that one lung. We lose the lung, but we can still have one functional lung, which sucks, but better than being dead. So what can I use? So right main stem. If the left side is bleeding, right main stem, I got this. It's easy enough, right? All you have to do is just be a little bit too enthusiastic about your intubation, and you go right down that right main stem. The left one is hard. So they talk about turning the patient's head on the side and using a bougie to try to redirect. I'm sure it's not as simple as that. You could, in theory, use the flexible bronchoscope. But again, I don't know in a bleeding patient how well, like how much my hands would be shaking to try to get that done. So if,
or you can just turn the two PT tube around.
right.
So the PT tube has this bevel towards one side. You curl it the other way and have the bevel pointing toward the left. You have a much better chance of hitting the left.
Say that again.
He's saying, you know how a T-tube has a curve to it?
Bevel toward the right. That's why, I mean, that plus the anatomy makes it tend to go to the right. You can turn the ET tube 180 degrees so that the bevel comes toward the left, but then now you got lecture the other way.
So that it goes.
That's how you can intubate the left.
Okay.
And for the purposes of exam and in real life, which way? We want the bleeding side down, right? Keep the blood down. Hopefully we can preserve one lung. So obviously you're going to do fluid blood product resuscitation, whatever you need. IR. Again, I do wish you luck in getting IR involved. But the problem is, so the reason they bleed so heavily is that these it's not just the pulmonary arteries which are there for gas exchange, it's also the lung tissue itself is very vascular, and those bronchial arteries are under systemic pressure, so they bleed heavily, and they bleed under systemic pressure. But theoretically, IR could be helpful if they're willing to go in and plug up the bleeding vessel. Again, I don't know how practical it is. And open surgery in extreme cases. So pericardial tamponade, sorry. You can't read it. It says pericardium wetsuit is so full of fluid, I'm having a hard time keeping my beat regular. So this one should be pretty straightforward because everybody knows pericardial tamponade, I hope. So it can be, so pericardial disease, and I included different things on a spectrum, can be in up to 20% of patients. It's more common than we expect. Sorry. Can be from metastatic cancer or from cancer therapy. The most common metastatic tumor involving pericardium is lung, because it's like right there. And other common cancers, again, things that like the chest, things that like our midline, which is breast, because it likes to metastasize, it's all right there. Esophagus, melanoma, lymphoma, leukemia, and sarcoma. And lymphoma and leukemia makes sense because I always think about like all the lymph nodes that are right there. Melanoma was a bit of a surprise. So you can have pericarditis, which is inflammatory, and pericarditis can be of gazillion different reasons. You can have pericardial effusion, again, can be of different reasons, which can progress to tamponade, or you can have constrictive pericarditis. And the rule is the rate and volume of fluid, and really the rate even more than the volume, is what determines how symptomatic you are. I remember when I was a resident, one of the attendings was telling this anecdotal story that they had a bulldog, and the bulldog had, it wasn't cancer related, but had pericardial effusion, and they actually trained this poor dog the dog was smart enough to realize if he sits still and puts up with the pain of the pericardiocentesis, which I do give credit to the dog, it feels better. And so this dog would put up, and they would do this like home bedside procedure. I don't know. Sometimes I think animals are cleverer than humans. So I found this cartoon. Beck's triad. Who's asleep? Everyone's awake. All right, so Beck's triad, right? You have distended neck veins, muffled heart sounds, hypotension, and you have clear lungs. And so basically fluid accumulates in a pericardium sac, the heart can't fill, which means nothing's going forward, and eventually you have cardiovascular collapse. And so subacute is more chronic in malignancy. It just slowly accumulates until they get symptomatic. Constrictive pericarditis is when the pericardium itself becomes progressively thickened because it's fibrosis or scarring, and can also cause pericardial effusion, can also cause tamponade just being so hard. So presentation can be very vague. Again, shortness of breath, chest discomfort, fatigue, and then, of course, the classic signs. Now, Palsis paradoxus, my personal one, other than on the exam, you will never do Palsis paradoxus. It's something that you can torment PA and medical students with, but I don't see it as a very practical one. Anybody who listened to this week's EKG Weekly podcast? No. All right. Anybody cares about spoiler alerts? What happened? You're listening. Okay. So low QRS voltage is pretty sensitive. Obviously, electrical alternans is something that's very specific but not seen very frequently. And the classic chest X-ray finding is cardiomegaly in the absence of CHF. So what's wrong with this picture? All right, it's a huge heart. It's like the entire chest.
Portable chest X-ray, can't tell.
I think even on a portable, that's pretty huge. And I try to find an EKG of electrical alternans. You can see it. You can see that it's like goes up, down, up, down, up, down. But again, you're not going to see it on the, you'll see it on the test. You won't see it in real life very commonly. Ultrasound. I know you guys are better than me at ultrasound at this point. So you will see a pericardial effusion. I can usually scan for that because I trained and we started using FAST at the time. And then you see RV early diastolic collapse. And then you'll see left RA end diastolic collapse, and then dilated IVC. So I think the first one is actually RV early diastolic collapse. Like they'll talk about the signs on the ultrasound. So other ways to diagnose, let's say you have no ultrasound, you're practicing somewhere very, very far away. You can do CT or MRI. The problem is it doesn't give you any functional information. So it'll just tell you if there is an effusion, but you don't know if it's pericardial tamponade or not. So in terms of treatment, so one thing on the test questions, you have to be careful. You have to pay attention to what it's asking you. And it can ask you what is the initial interventions or what is your next step. And that's going to be something straightforward. It's going to be your ACLS, your BLS. And then sometimes it'll talk about definitive treatment, which is who is actually going to fix my problem. So example is appendicitis. I guess technically your next step is call the surgeon, but you're also going to give them fluids and you're going to give them antibiotics, and definitive treatment is surgery. So acute treatment, you can give them fluid bolus because that might be enough. Give them a little bit of a preload, and that might be enough to buy you some time. And of course the next step is they need pericardiocentesis. Even getting a little bit of fluid out can make a difference in terms of hemodynamic status. Whether you want to do it at bedside, I know on our campus, but it was daytime. So the patient came with a diagnosis. She was taken to cath lab, and they put the catheter in. And then definitive treatment is to prevent reaccumulation. So that particular patient had pericardiocentesis, then left the catheter in. It drained for a few days, and hopefully that's enough to prevent reaccumulation. Wasn't in the case of my particular patient. And then they have an option of pericardial sclerosis, which sounds really scary because they're putting in sclerosing agents around the heart. And hopefully everything gets kind of glued together. And then, of course, there's surgical decompression, pericardial window, and intrapericardial chemotherapy. Sounds ouchy. All right, so the last one, SVC syndrome, again, something we don't see very much. And it's not unique to cancer, so I thought it was an important thing to talk about. So our SVC, and there's a tumor, and there's the lymph nodes. And pathophysiology, similar in a way to everything we've talked about. It's local obstruction of tumor. So either tumor or lymph nodes are blocking the flow of blood from the SVC, which means everything above the SVC, so your upper arms, your face, your brain, is at risk for, you can't get the blood down, so you're going to have increased pressure there. So it can be either direct invasion, or you can have compression from a locally growing tumor, or you can have it from thrombosis. And same thing, how fast you develop symptoms depends on how fast the problems develop. So if I have time and my body can form collaterals, then I may not be asymptomatic. And if it's an acute thrombosis, I will feel much worse about it. So I threw an etiology, pre-antibiotic era syphilitic thoracic aortic aneurysm. And there was a picture I once saw where this skinny woman with this giant thing that looked like a goiter. And I was like, what does this have to do with anything? And it turns out this is what, like, so before penicillin, tertiary syphilis. This huge thing grew in their chest, eroded through, and eventually burst the aorta, you know, and that's how you died. More recently, thrombosis, so that's common, like a very common thing, because it can also be iatrogenic. Our central lines, if you think about all the renal patients that are walking around with portacaths, thank you. So they're definitely at risk. And there was a patient, I think she passed away a few months ago. She had that. She had a known SVC syndrome. So obviously any malignancies that live in a thoracic area and lymphoma, just because of how big the lymph nodes can get, can cause these problems. And that's another picture. So if you have your tumor, you're going to impede the blood flow from the head and from the neck. So the most common symptom is dyspnea, which is a very non-specific symptom. I'm like, come on, give me something I can work with here. It can be cough, hoarseness. That was an interesting one to me. And then the more classic stuff, facial swelling or fullness. And it's worse with lying down or facing forward, so similar to all of our increased ICP symptoms. You can have arm swelling, you can have chest pain, you can have dysphagia. And also, because if you have enough trouble, you can have increased ICP, you can have your headaches, you can have confusion, you can have coma. That was kind of a surprise to me. I didn't know that SVC syndrome can get so bad that they can go into a coma from increased intracranial pressure. So on a physical exam, you may notice that the face and the arms are swollen. You can notice neck and upper chest vein congestion, facial plethora, that means red face, ICP increased, papilledema. How many of you actually look for papilledema? Right. And then palpable supraclavicular tumor mass, maybe. So I threw in some pictures because your exam has visual stimuli, I assume? Yeah, you got pictures? So this is a pretty classic one. They're talking about venous congestion and collaterals. And this one is facial plethora. And I think these little red spots are supposed to be telangiectasials, which is little subacute dilated capillaries. So the first test in terms of diagnosis is going to be your chest x-ray, because oftentimes you will see that there is a tumor there, there's a problem, pleural effusion, mediastinal widening. Venous duplex of upper extremity can be very helpful. It won't image SVC, but they can tell you what's going on in your axillary and your subclavian, and then you can infer. If you have problems there, you know there's going to be more problems down the line. And it should be for patients with indwelling catheters, which is your chemoport patients or portacath patients. That's a good test to start with. Who's falling asleep in the back? So other test of choice. So the practical one. So what realistic test I can order to rule this out in the ER? CT with so I have to give contrast. And that's a big problem. So if I can do CT with contrast, then that's a great study because I'll see the clot. If I can't, you can use MR venogram. Again, the problem is trying to get the MRI. It is a big ordeal. But the good news is it's nice for patients that have dye allergies. And these days, I feel like 50% of my patients have some sort of dye contraindications. But it can be difficult to obtain. So again, there's the ER treatment, and then there's the definitive treatment. So in the ER, your true emergency consists of either airway compromise, because there's so much swelling that now you have developed stridor and airway edema, or if you're going into coma because of increased ICP. Obviously, address the airway. It's always on, where are people? We worry about the airway a lot. And then in terms of increased ICP, you raise head of bed. Apparently that's actually a minor intervention, but has been shown to be really, really helpful. If it's thrombosis, then you want to do systemic anticoagulation. Steroids is really for laryngeal edema or for steroid-sensitive malignancies. So I'd probably ask my oncology if I should start with, unless I had clear indication of just airway edema. And then diuretics. And so definitive treatment, which again, most of it is not going to be done in the ER. You can do chemo, you can do radiation. This was pretty cool because IR can do endovenous stenting. And they can do TPA, they can do venous angioplasty. And this is a better test if you need something quick, because chemo is going to take probably weeks. Radiation is probably going to take weeks. But the stent can go in sort of quickly, hopefully in 24 hours. And then surgical venous bypass, patients with severe symptoms, but also patients with a decent life prognosis, because you have to be able to withstand surgery. All right, that's the last slide. The surgeon's nod should never give away.